Hello and welcome. I'm Fernando, a GP in the UK. Today, we were supposed to look at the NICE updates relevant to primary care published in June 2024. However, this month we have had no new guidance relevant to primary care because they were all connected to secondary care such as surgical techniques, chemotherapy agents, and acute myeloid leukemia amongst others. So instead, we're going to look forward and review the guidelines that are under consultation, which will lead to new or updated guidance in the coming months. Because they are in draft form, we're only going to give them a quick overview. There are only 4 areas, so today will be a brief episode. So let's jump into it. The first consultation is on house dust mite sublingual immunotherapy for treating allergic rhinitis and allergic asthma caused by house dust mites. This is referred to by NICE as 12-SQ-HDM SLIT, which is a tablet also known as Carisax, which has been already authorized by European regulatory authorities. Let's have a look at some key points. It is recommended for house dust mite-induced allergic asthma that is not well controlled by inhaled steroids, and mild to severe house dust mite allergic rhinitis, but it is only approved for adults aged 18 to 65 years of age. From a patient's perspective, these conditions can be debilitating and they have an impact on daily life. Although there are other treatments available, their management can be challenging when triggers are unexpected or outside people's control. House dust mite sublingual immunotherapy involves the administration of allergens, in this case house dust mites, under the tongue to desensitize the immune system to these allergens, reducing symptoms over time. It is done using a sublingual tablet that dissolves under the tongue. The goal is to gradually train the immune system to tolerate the allergen through desensitization or tolerance induction. The treatment typically lasts several months to a few years depending on the patient's response and the specific protocol being used. Over time, patients usually experience a reduction in symptoms and long-lasting relief even after the treatment has ended. It is generally considered safe, with the most common side effects being oral itching or discomfort. Serious allergic reactions are rare but can occur, so initial close medical monitoring is recommended. The effectiveness can vary depending on the person, and it is an alternative to subcutaneous immunotherapy. The sublingual route is preferred because of convenience and a better safety profile due to lower risk of severe allergic reactions. The next consultation is on new quality statements on bacterial meningitis and meningococcal disease. The statements that we should be aware of in primary care are that people who have had bacterial meningitis or meningococcal disease should have an audiological assessment within 4 weeks of them being well enough for testing, and a follow-up appointment to secondary care within 6 weeks of discharge from hospital. In the third consultation, NICE evaluates various digital self-management technologies for adults with COPD. These technologies aim to support patients in managing their conditions at home, potentially reducing symptoms and improving patient outcomes. Some of the key technologies being assessed include digital platforms that offer pulmonary rehabilitation, remote monitoring, weekly check-ins from healthcare professionals, educational modules on exercises and medication, and mindfulness exercises. NICE states that, although a digital technology will not replace face-to-face appointments, offering digital technologies as an option could improve access and reduce symptoms and exacerbations. Furthermore, there have been no safety concerns for this type of supported self-management. And the final consultation is a very important one for us because it is an update on asthma. The draft guideline on the diagnosis, monitoring and management of chronic asthma has been produced collaboratively by the British Thoracic Society, NICE, and the Scottish Intercollegiate Guidelines Network, or SIGN. It will update the previous 2017 NICE guideline and the 2019 BTS SIGN guideline. It will not cover the management of acute asthma. The update reviews questions like, for example, whether spirometry with bronchodilator reversibility should be routinely used in the diagnosis of asthma, or whether the bronchodilator response, using peak flow or FEV1 should be calculated as a percentage change from the baseline result, as it is now, or change it to being related to the predicted FEV1. The draft document is large, so I will not be able to summarize it here. Besides, it will be better to wait for the final guidance just in case the recommendations change at the last minute. But at least it gives us some awareness of what it is to come on that front. We have come to the end of this episode. Remember that this is not medical advice and it is only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching and goodbye.